So, good evening, friends. On behalf of all of us, the team Inches Academy and the eager participants, I welcome Dr. Sanjeev Badhwar. You know, I have not told you all that how fortunate I am to meet the right consultants when needed. Now, Dr. Badhwar is not from Bombay. He is from Armed Forces Medical College. I practice in Kalina. He is in Andheri. And as luck would have it, when I needed something, a chance meeting, and then realizing the sincerity in the profession, which you all will agree is today missing a lot, I have become a very good friend of Dr. Badhwar. He has operated on at least 40 patients of mine, several family relations, and we have always been satisfied. So I have been talking to him for a long time of doing a CME program, but pre-COVID era, the CMEs were only done face to face, and we always, never could decide a date and time and all that. So now that we have started this from June, and then when I discussed with you all that I want to keep a series of update, then ENT was a very good thing in my mind because painful year with almost 80% doctors not having an otoscope in the clinic. A swollen canal, you hardly can see anything. How to manage is a challenge. And then talking to him, seeing my patients who are developing deafness, either age related or otherwise. I have been talking to Dr. Badhwar a lot about hearing management. So then I thought that I will request him to talk on this. Dr. Badhwar, we have a very eager audience. For doctors who are practicing in the evening and cannot attend, we run a replay of this tomorrow from 4 to 5:30. And collectively, we are able to reach around 3 to 400 doctors. At the beginning, I would like to ask your permission because what we have decided is these 6 update programs we would like to put on YouTube. But if you give us permission, we will put this on YouTube for future reference of doctors also.
There are no issues with that, sir. Good evening, sir, and
Good evening,
friends. And it's an honor to be with you.
Sir, you'll have to speak little louder because your voice is coming very faint.
Okay, can you hear me now? Is it better?
Now we are able to hear you.
Okay, so good evening, friends, and it's an honor to be with you. My talk today is divided into 2 parts. Like Dr. Asrani sir said, first, what is the approach to the painful ear? That's part 1. And the second part would be, what are the newer advances in hearing management, be it in the diagnosis, be it hearing aids, and be it surgical interventions. But before I start, our journey in Kokilaben began 12 years ago, and my first implant in this hospital was kind courtesy of Dr. Asrani. Thank you, sir. So today's talk is approach to painful ear and recent advances in hearing management.
So Otalgia, what is Otalgia? Basically, painful ear. It is defined as pain in the ear or earache accompanied by a bloating sensation, sometimes a blocked ear sometimes. The probable causes include infection in the external ear, middle ear, trauma to the ear, or referred pain. What are the etiology and risk factors?
The otalgia can be related to infectious processes in the external ear or the middle ear. Sometimes bacterial contaminants can enter the ear due to insertion of unclean articles, fingers, toys, and currently, because so many online classes are happening, we're getting a lot of patients coming in with external ear infections. Sometimes, insertion of sharp objects into the ear canal can traumatize the skin and provide an open medium for infection. Sometimes, this could also traumatize the tympanic membrane. Penetration of contaminated solutions in the ear canal, swimming in polluted water, also increases the probability of ear infections. We get a lot of patients coming in with ear infections. We ask them, "Have you been for a swim?" They said, "Yes, doctor, in our society swimming pool." So the biggest culprit is the swimming pools maintained by some societies which are not cleansed properly. Their filtration plants don't work. So a word of caution for this. So, just to broadly summarize, a painful ear could be because of conditions in the external ear, hematoma, frostbite, sunburn, perichondritis. That's another cause. You have these young girls coming in who've been for ear piercing, not one, two, but three to four, and they land up with perichondritis, neoplasia at times, or in children, an infected preauricular sinus. In the ear canal, you can have impacted wax, foreign bodies, a condition of impacted wax called keratosis obturans, external otitis, herpes, extremely common and sometimes missed in the pre-eruption stage. In the middle ear, you can have bullous myringitis, acute otitis media, secretory otitis media, hemotympanum, perforations, and of course, all of you know mastoiditis. And in the inner ear, you can have acoustic trauma, Meniere's, or a schwannoma. So, otalgia related to a problem in the ear is usually the result of an inflammatory process. Chemical mediators are released which cause edema, pain, heat, and redness. This results in swelling of the tissue, and you have the ear is richly innervated, so it's extremely painful. We've covered this. So, what about wax? The most common question asked is, "Doctor, how do I clean my wax? Do I clean it? If so, what frequency?" Now, wax is a normal secretion of the sweat and sebaceous glands, which nature has made to make the ear waterproof. And it does not have to be addressed unless there is pain, discomfort, or a hearing loss. The skin cells migrate from the tympanic membrane outwards, and the ear is shaped like an S. So, if you leave it alone, wax does not accumulate. The minute you put in earphones, the minute you put in earbuds, earpods, this migration is arrested and impacted wax becomes more common. This is another thing which is happening because everyone is online, everyone is using AirPods. So, a lot of people are coming in with wax. So, the take home message is we don't recommend that you have to keep cleaning the wax unless you have a hearing issue or you have pain or discomfort. We normally recommend if the wax is to be cleansed, please meet your doctor. Don't try to remove it by yourself. And the simple thing of using olive oil at room temperature once a week, one or two drops in the ear, softens the wax and prevents a buildup. Sometimes wax can present with pain, deafness, or tinnitus. So normally we soften the wax and the wax is removed either by suction or irrigation. The old adage of using hydrogen peroxide is not recommended. Foreign bodies. Now, there's so many foreign bodies which go into the ear, you'd be amazed. You go out for a camp, you go to the beach, you go out in the mountains, you have insects like these coming in. You have small objects which may come in, flies, cockroaches, or sometimes in the early childhood, 1 to 2 years of age, children tend to put small objects in the ear. As far as animate objects are concerned, if a fly goes in, use whatever you have at hand, be it generally you may have coconut oil, olive oil ready. please put a few drops of that to stun the insect so it doesn't move around. And this has to be syringed or removed. Sometimes in children, foreign bodies are impacted, especially vegetative ones, like the one seen below, and with the local reaction which takes place, it becomes difficult to remove in the clinic setting. These have to be removed under sedation. One attempt can be done to remove the foreign body at your center, but if you fail in that, please refer him to your nearby ENT clinic. Furuncle in the ear. As you can see, and like what Dr. Asrani said, the ear canal, the skin is extremely tight. And any inflammation, even a small boil, becomes very, very painful. The common causes for this are again water, towels which are not, which have been used or frequently, visits to the train. All these things can cause a ear infection. Sometimes even what is popularly used as ear trimmers can also cause this. So basically, you have a painful swelling in the outer third of the external auditory canal. So how do you treat this? Now, in this, you see the old time treatment works extremely well. You have a product called ichthymol glycerine, which is not commonly available, but Royal Chemists next to Bombay Hospital makes this. So all you have to do is put a cotton wick soaked in lukewarm ichthymol glycerine in the ear canal. Within 24 hours, the swelling settles down. Otherwise, easily available local measures are using T-bact or fusidin cream and appropriate antibiotics. Sometimes a large abscess can form and would have to be drained. Recurrent ear infections, furuncles, you need to do an MRSA swab and check the blood sugar levels. Otomycosis. Now, this is a fungal infestation of the ear and is extremely common in our city because it's humid, people sweat a lot, and again, earphones, people in call centers, the ear canal is always blocked, and they're coming in with such infections where even if you just shine a torch, you could see whitish, blackish, this thing material in the ear. Again, it's extremely painful. So the treatment for this is topical drops, which may be antibacterial, antifungal. You have to remove this, and they're treated normally with a course of broad spectrum antibiotics and sometimes antifungals for a period of 2 to 3 weeks. This may require a visit to the ENT surgeon. So you have itching, you have pain, you have discharge, and oral toilet has to be done. Myringitis. This is a viral infection where you have small blebs on the tympanic membrane. Vesicular eruptions are seen. Sometimes may have bleeding or serious discharge. This is treated symptomatically with analgesics and antiallergics and topical drops. And normally it settles down because it's a viral manifestation. Acute otitis externa can be because of hot, humid climate, as you've talked about, swimmers, trauma to the ear. Sometimes existing chronic otitis media, you can have secondary otitis externa. The normal organisms in long-term external otitis are staph, bacillus, and pseudomonas. And like you know, nowadays drug resistance is so common, so regular oral toilet is extremely important. You may have a hot burning sensation, pain, discharge, cheesy debris. So medicated wicks work extremely well here. And good old ichthymol glycerine, I would recommend very, very strongly. It's a simple medication and works wonders and should be part of your clinic. So these are the other factors which can cause recurrent external otitis. Now, when you have this, just briefly, when you have chronic otitis media leading to painful ear, firstly, you treat the infection, you treat the acute otitis media, And when you have a permanent uh, problem of a discharging ear, then surgical management is called for. It could be myringoplasty, tympanoplasty, ossiculoplasty, sometimes myringotomy, and rarely mastodectomy. This is just to complete the list. Now, this is a problem which I'd like to dwell on: malignant otitis externa. This is becoming extremely common in our practice. When we were doing residency, we used to see one odd patient every 3 to 4 months, but now we see at least 4 to 5 every month. This is basically happening because of long standing, uncontrolled diabetes. The word malignant is because, although it's not malignant, it's extremely difficult to eradicate and has to be addressed extremely scientifically. The treatment normally goes on for about 6 to 8 weeks. So essentially, it's common in long standing diabetics, uncontrolled diabetics, brittle diabetics. The patient may present with discharge from the ear, debris in the ear, excruciating pain, which is more common at night, sometimes a facial palsy. So, first, a general medical examination. Most importantly, a oral swab is to be taken, because nowadays drug resistance is so common that we always recommend use the appropriate antibiotics, especially when you're going to be using it for 6 to 8 weeks. So the first step is to take an oral swab, do an oral toilet. Once your swab is with you, these cases sometimes respond very well to a simple oral antibiotic like Ciplox, which is given to 6 to 8 weeks. But the most common organism is Pseudomonas. And like you know, it's extremely frustrating to treat. So herein you have to give IV antibiotics for a period of 6 to 8 weeks, control the diabetics, and early days, surgical management was the first line of management. Today, it is medical management, diabetic control, oral toilet, and for very, very severe cases, we offer hyperbaric oxygen therapy, one sitting per day for a period of 10 to 12 days with very gratifying results. Despite all these measures, sometimes the patient's pain does not settle down. In such cases, we always do an ESR, which is to give a baseline into how we're going to manage the infection, a CRP, an MRI of the ear, of the temporal bones and skull base, and sometimes a bone scan. So this gives us a guideline into our management. And with patients who do not get adequate pain relief, despite all these measures, a radical mastodectomy is done to debride all the devitalized tissue, which normally results in good pain management. So our end point in management for these patients is one, getting our CRP and ESR within normal limits, seeing an appreciable improvement on MRI and pain relief. So if you manage it well, if you manage it scientifically, you do get good results, but it is an extremely frustrating disease to treat because multiple doctors have given multiple antibiotics without taking a swab. You don't know what you're dealing with, and the patient is in pain and agony. So normal pain management with analgesics, sometimes we use gabapentin, a buvolol patch also at times does give good results. But essentially, I would repeat again, an oral swab, antibiotic management for 6 to 8 weeks, monitor with your ESR, CBC, CRP, MRI, and if indicated, a bone scan. Surgery comes in only for very severe cases. If someone, like you can see, suddenly has a facial palsy, then the facial nerve has to be decompressed, or if despite all these measures, the pain management is not satisfactory. Another condition causing severe pain is herpes zoster. This is a viral infection affecting the genital ganglion of the facial nerve. So this condition sometimes miss because patients come with severe lancinating pain and you don't have the vesicles. So this is in the pre-eruption stage. So if the patient has severe pain and you really can't see any infection, any furuncle, this should be at the back of your mind. Have a high index of suspicion. So once the eruptions start, the diagnosis is perfect. You can see the vesicles. Sometimes the vesicles are in a limited segment. Sometimes they go on to what is called the classical Ramsay-Hunt syndrome, where you have vesicles, you may have hearing loss, you may have giddiness, and you may have facial nerve palsy. The management is for a period of 10 to 14 days with antivirals, be it acyclovir, femcyclovir, or valsivir, and limited oral corticosteroids and local measures. But post herpes, pain is quite severe. They are again managed with analgesics, gabapentin, sometimes Tegretol. So sometimes, despite a quick and a good result, you may have pain which may last for a month or two, and it can be quite severe, and the patient has to be managed accordingly. Now, another common question: acute otitis media. How do you handle it? So basically, the presentation can be different. If you have a child, if you have an adult, the child classically wakes up at night with severe pain, severe lancinating pain. The child goes to bed after dinners, middle of the night wakes up. This happens in an adult, it can happen at any time. So you have a feeling, a sensation of pain, you have a sensation of blocking of the ear. Sometimes you may even have a decreased hearing acuity. The common pathogens are Streptococcus, Haemophilus, and Moxarella. The predisposing factors are anything which interferes with the normal function of the eustachian tube. So this could be a pre-existing catarrh, nasal infection, swimming. Now it's very common, scuba diving, deep sea diving, or a long flight. You may have deafness, you may have pain, you may have ear discharge, and a red, congested, bulging TM. Sometimes you may also have a small perforation with ear discharge. Management, evaluation, examination of the ear, sometimes a tympanometry, and if the acute otitis media has been there for more than 10 days, then sometimes a scan is recommended. What is important to note is broad spectrum antibiotics are given for a period of minimum 10 to 15 days. Normally, we give it for 4 to 5 days, the patient feels better, and we stop. But for adequate management of acute otitis media, period of 10 to 15 days is recommended, along with nasal decongestants, sometimes nasal sprays, ear toilet where indicated. Now you have a condition called persistent otitis media. Despite all measures, 15 days, the patient is still not okay. You may do an X-ray mastoid, which shows a dull haziness of the mastoids, or you may do a scan, and the patient is not comfortable despite 15 days of adequate medical therapy. In such cases, a myringotomy is done. A myringotomy is a simple procedure done under local anesthesia, outpatient procedure, where a small radial incision is given on the tympanic membrane and the pus or the fluid is drained out, giving immediate relief. Another common thing which is happening now is otitic barotrauma. This is normally seen long flights, normally happens during descent or while diving. There's sudden lancinating pain in the ear, and the patient is extremely uncomfortable and presents with, as you can see in this, a bluish, darkish tympanic membrane. So basically, this is due to a failure of the eustachian tube to maintain adequate middle ear pressure at the ambient atmospheric level. The function of the tube is to equalize the pressure between the nasopharynx, the atmosphere, and the middle ear. So during rapid descent, sometimes either uh, during a flight or either during diving, fluid collects in the middle ear. So you may have earache, you may have hearing loss, tinnitus, or sometimes a ruptured hemotympanum. So the treatment for this is nasal decongestants, antihistaminics, analgesics, and sometimes when all these measures fail, a myringotomy is offered. How do you prevent it? Swallow during descent. Do not sleep during descent. Auto-inflation of the tube. It's also recommended to either use chewing gum or sip of water or a drink during descent. And what happens when you fly and you find small children crying during descent? Feed the child. The child will be comfortable. Sometimes, despite all these measures, you don't succeed. So, what is new in this? A new procedure which has been in vogue for the past 1 year is called eustachian tube dilatation. Now, this works wonders for otitic barotrauma. As you can understand, the eustachian tube is not equalizing and uh, middle ear has fluid. So, for a quick result, especially for someone who's an airline pilot or is working professionally, he has to fly and he cannot take a week off, is normal medical management and under local or under sedation, a tube goes into the eustachian tube under nasal endoscopic guidance, and the eustachian tube is inflated with a balloon, and the balloon comes out. This is giving wonderful results, and I would highly recommend you to advise this for your patients who have recurrent otitis media with effusion, divers, aircrew who keep having these issues. But of course, you also have to look for the primary cause. So this could be that they flew with a cold, they have a gross deviation, they have nasal polyps, or sleeping while descent could cause this. Another very important cause of ear pain is acute mastoiditis. So simply it is inflammation of the mucosa and the mastoiditis system, which normally follows acute otitis media, which has been there for some time. Now, in the antibiotic era we are in, it's not so common, but we still do see it. So you can have pain behind the ear, fever. Your discharge is important. If you have a index of clinical suspicion, the discharge initially is watery and then becomes creamy or a little thick. This leads you to a suspicion that the patient may be going in for acute mastoiditis. You may have mastoid tenderness, and if you could see with an otoscope, the posterior wall of the ear, they may be sagging, or the patient may have high grade fever. So, such cases need inpatient care. Again, if there's discharge, a swab is taken, a scan is done. If you don't have the facility for a scan, if you do an X-ray, you see what is called as breakdown of the mastoid septae. Antibiotics and supportive medications are given. Myringotomy at times, if the pus is under tension and you need a swab to find out what antibiotic will work. When all these measures fail, then a cortical mastodectomy is called for. Complications of acute mastoiditis, you may have facial palsy, labyrinthitis, and rarely intracranial complications. Now, this is extremely important. Referred otalgia. Referred otalgia, in simple terms, basically you have ear pain, but the primary site is elsewhere. And you can imagine there's so many structures around the ear. So, really, you have to do a diligent search. So basically, the pain will generally be felt in the territory that the nerve serves, that is the somatic dermatome, even though the damage originates elsewhere. So basically, you can have referred otalgia via the trigeminal nerve, dental causes, oral cavity, you can have an ulcer, malignancy, Ludwig's angina, sinusitis, a calculus in the salivary gland, and the next one, which is extremely important and common, is temporomandibular joint arthritis or dysfunction, which is extremely common in those who masticate at night. Those who have a clicking sound in the ear, they present with severe ear pain. Sometimes nasal conditions, polyps, sinusitis may cause referred pain. Adenoids, the CA nasopharynx, trigeminal neuralgia, glossopharyngeal neuralgia, parapharyngeal abscess, Eagle syndrome. These are some of the causes of referred otalgia. Herpes, we've already covered. You may have cervical spondylosis. So this is basically the etiology of referred pain to the ear. We can have it in the auriculotemporal nerve, the tragus, the greater auricular nerve, lesser occipital nerve. So the ear is richly innervated, and all these nerves serve different territories, and they can cause pain, which is referred to the ear. I'd like to dwell upon Eagle's syndrome. Basically, you have an elongated styloid process, and the patient keeps coming back to you, telling you that, Doctor, I have severe pain in the ear. It is aggravated while swallowing. It is referred to the ear, and I am not comfortable. I have taken antacids. I have taken antibiotics. I need help. So basically, here you have to do a diligent clinical examination. The tonsil may or may not be enlarged. You need to palpate the tonsil, and sometimes you can feel an elongated styloid process. And when you touch that, the patient says, Yes, doctor, that's where the pain is. So, a clinical examination followed by a good x ray, or if you don't get good results with that, a CT scan will tell you that the styloid process is elongated. So, the elongated styloid process abuts on the glossopharyngeal nerve and causes these issues. Now, every patient with eagles, you don't operate. You normally give a course of analgesics, gabapentin, tegretol, and a trial of medical management is carried out for a period of 1 to 2 months. If your patient is comfortable, nothing more to be done. If not, then you have two options. In today's day and age, you may do a regular tonsillectomy. After that, the styloid process is exposed and the tip is excised, leading to extremely quick relief of pain. If you have the facilities, then in such cases, a robotic approach is preferred because you can actually do a extremely precise dissection, visualize the styloid process, visualize the glossopharyngeal nerve, and excise the tip with extremely gratifying results. Sometimes you may have pain in the ear because of cervical spondylosis. That a good clinical examination will guide you. So here again, analgesics, good physio, and lifestyle, what you call management. Everyone is addressed, stuck to the laptop for hours, and you may have referred pain. So how do you evaluate otalgia? Ear symptoms, nasal symptoms, swallowing disorders, trauma, general symptoms. A complete physical examination, an ENT examination, which would include a rhinoscopy, nasopharyngoscopy, a laryngoscopy or a Hopkins, and palpation of the neck is extremely important. Diagnostic tests may include a CBC, hearing test, otoscopy, mastoid, barium swallow, CT scan, sometimes an MRI for malignant otitis externa, and diagnostic anesthetic blocks may be called for. These are some of the children we've treated in our institution for hearing loss, and these are some of the patients who've been operated for a cochlear implant. The next part of my talk would be on hearing solutions. Before we move on to that, what is new in ENT? So basically, when we started ENT, all we did was SMR, rarely ears surgery, and tonsil. We just had three procedures and a cardiac luck. So ENT in our generation has come a long way. So today we offer robotic surgery for sleep apnea and head neck, what you call thing, pathology. We'll be talking on this next week. Balloon sinuplasty, cochlear implants, laryngology and swallowing, endoscopy, that is endoscopic removal and treatment of salivary gland disorders, difficult airway, and skull base surgery. I'll just be moving on to my next talk. So to complete today's talk, one was painful ear. The next step is a commonly asked question in how do you deal with hearing loss. So I thought recent advance in ENT, let's stick to the ear. So I'll just briefly talk on hearing health and cochlear implants. Before we start, I'd like to mention the fact that today our government is doing a great job in addressing children with hearing disabilities. There are two schemes. One is a scheme run by the Ministry of Family Welfare, which is called the ADIP scheme. And the second one run by the government of Maharashtra called the RBSK scheme, where,
Dr. Badhwar, I'll interrupt you for a minute.
yes, sir.
Please tell one of your team members to create a slide of your contact details because people are asking.
Right, sir.
So your
Yeah,
contact details, email ID, telephone number,
yes,
all that
yes.
in.
Yeah, at the end of the talk, I'll do that, sir.
Yeah, yeah, yeah.
So the RBSK scheme by the government of Maharashtra is incredible, sir. Believe you me, like you saw these children, they are coming from Jalna, Aurangabad, Osmanabad, Akola, from all over. The implant is totally funded by the government. The hospital stay is funded by the hospital in question. And what is most important, the post implant therapy is totally taken care of without the patient spending a pie. So here you have an initiative by our government which is really unique in the entire world, where a child who comes from a poor socio-economic background, I'll show you the figures later, can be operated upon without spending. The only thing is you need to have good documentation and the child has to be referred. So now talking on hearing health and cochlear implants. What is the prevalence of hearing loss? So the WHO estimates 9% of children and 91% of adults have hearing loss, of which 56% are males and 44% females. But the main problem is that hearing loss treatment is not so easily accessible throughout the world. In the West, Europe, USA, Australia, anyone who has hearing loss can afford to be treated, be it with hearing aids, be it with surgery. But in our part of the world, it's extremely tough. Hearing loss in children in India, approximately 400,000 children today under the age of 4 have severe to profound hearing loss. Approximately 100,000 additional children born each year have severe to profound hearing loss. Of these, fewer than 1,000 under the age of 4 have received cochlear implants. What is extremely sad is this is something which is correctable. And our endeavor is every child with hearing loss should be identified with a universal hearing screening, operated by the age of 2 to 3, and attend normal school by the age of 5. That is our endeavor. So, this is the global hearing loss estimate. And the total number of cochlear implant recipients as on 2010 was 180,000, which is still extremely low. So before we move on to implants, briefly, how does hearing work? So you have the outer ear, the middle ear, and the inner ear. So the outer ear captures the sound, the drum vibrates, your three ossicles amplify the sound into a small place called the oval window, where it moves into the endolymph. The hair cells sense the sound, and this is transmitted to the auditory nerve. So again, sound waves move through the ear canal, vibrate the eardrum, the fluid moves around, hair cells sense the change, which send signals to the hearing nerve, and you hear sound. It's a beautiful thing. What are the types of hearing loss? So basically, hearing loss is of three types. The classical sensorineural hearing loss, which occurs where there is damage to the inner ear or the nerve pathways, also known simply as nerve deafness. Here, the treatment is more or less standard. Either the patient is in the range of hearing aids, where we can amplify the sounds into what we call the speech banana, or if the hearing loss is severe, we address it with cochlear implants. But a lot of work has come into the next segment, which is called conductive hearing loss, where the sound does not travel effectively from the outer ear canal, the eardrum, the bones, or the ossicles of the middle ear. So the problem is in the middle ear. The next is a mixed, where there is a bit of conductive loss and SM loss. How do you diagnose it? Basically, in children, we do behavioral tests. We see their response to rattles, bells, calling out, music, sounds. We do physiological tests. So you have what is called a BOA, which is a behavioral observation audiometry with different instruments, conditioned responses, pure tone audiogram. You do a tympanometry, which is basically to check if there's any fluid in the ear. You do an ABR, ASSR. But what is important, which you could think of keeping in your clinic if you have a pediatric uh, subset, is OAE. OAE is otoacoustic emissions, which is just like an otoscope. In a quiet room, you just point it into the ear and you get pass or referred. If it's pass, the hearing is essentially normal. Refer means you have to refer the patient to an ENT clinic. I would recommend you consider keeping an OE in your clinic, and if you need any help, we'll be happy to partner with you. Now, speech audiometry. Basically, you see, now we get this problem a lot, and you also must be facing this a lot, where people say that they can hear the sound, but they cannot analyze the speech. So we get faced with people who are working in noisy environments like pilots, aircrew, where because of being in the occupation for 5 to 6 years, they show evidence of hearing loss when they do their annual audiometry or medical exam. So what helps them here is, as clinicians, please refer them for a speech audiometry. So they may have hearing loss, but if their speech discrimination score is good, then I would clear him for his current occupation. So I just put this slide to enable you that if someone is in occupation which demands good hearing and he's been in that occupation for some time, his annual examination shows some element of hearing loss. If you wish to clear him, if you wish to help him so that he continues with his job, ask for a speech audiometry where we have certain sets of words which are given to the patient and a score is carried out. And with a good score, more than 60 to 70%, he can be cleared. So speech audiometry is extremely important. So what are the treatment options for hearing loss? There could be hearing aids. This could be something new, a bone bridge implant. I mentioned it. One of the first bone bridge implants in Mumbai was done courtesy Dr. Asrani for a patient with single-sided hearing loss. And cochlear implants are for those with profound hearing loss. So the main thing is to understand the concept of neural plasticity. So if the child is born without hearing, the center for hearing in the brain will atrophy if not stimulated. So, till the child can reach the concerned specialist, till any intervention is carried out, it's extremely important to stimulate the ear consistently with music, with rattles, and hearing aids. So, basically, hearing aids are extremely small devices which make sound louder by amplifying sound into the middle ear. As you can see through this, you have different kinds of hearing aids, and hearing aids have come an extremely long way since uh, since they started. Because the common refrain with anyone who has used hearing aids, I know my mother gave me the same feedback: son, everything is louder. I cannot understand. And it's more irritating to wear it, and I feel comfortable without it. So that has changed. So, how does a hearing aid work? Basically, sound comes in, and now you have hearing aids with multiple channels where all these factors can be addressed, be it feedback, be it a particular kind of sound which you are exposed to, and these are customized. So, one improvement is you have digital aids which are amplifying the frequencies you need To the larger number of channels, you have hearing aids which automatically change their mode. Are you in a quiet room? Are you in a conference? Are you watching television? Are you in a theater? The next important development in hearing aids is direct streaming. So you see now with children overseas, all the old parents staying here come and tell me, doctor, I cannot talk to my children overseas. I'm extremely depressed. So here this direct streaming has really made things extremely good for the patient. With direct streaming, they can really talk well, they can hear well. This can come from the television, from your laptop, from your phone, and this can be programmed accordingly. The next important development in hearing aids is the biggest pain, because I know this, I face this when I got hearing aids from my parents. My father says, son, I'm 80 plus, I cannot change the battery. It is a pain doing it. So you have rechargeable hearing aids. This is the biggest problem we used to face, where you have to change the battery every week. It's extremely difficult for someone who's 70 plus to open it and put a small cell battery in and every week, ask for a change. So the rechargeable batteries have made life easier. So one, digital aids, number of channels which adjust to different modes, direct streaming, and rechargeable aids. The other new development hearing aids which I would like to bring to your notice is remote programming. So you don't have to keep, now in the COVID era and all that, you don't want to come every time to a hearing aid center to get your hearing aid checked. So remotely, your service provider can check your hearing aid and programming can be done. So these things have made a world of difference. And if your patients need anything further on this, please feel free to contact us. And again, in this COVID, post COVID state, we have to change the way we work. So we uh, make it convenient for the patient for remote, help for the hearing aids. And for senior citizens, we also offer home service, be it for hearing, be it for hearing aid management, so that they don't have to come to hospital setting. So as far as conductive hearing loss, what has changed is basically uh, these are for children and adults with conductive hearing loss, mixed hearing loss, and single-sided hearing deafness. Now, again, to bring to your notice, we published a paper on this. During the COVID times, everyone has heard about smell, taste. But another thing which we have seen at least 5 to 6 patients in the past 6 to 7 months, which is a large number of patients coming with sudden hearing loss. So suddenly they've been exposed to COVID or they have been asymptomatic. And when we've checked, we found COVID antibodies and they're coming with hearing loss. So that's called sudden hearing loss. So this again is addressed with antivirals, steroids, hyperbaric oxygen, and we wait for a period of 3 months for recovery. If not, then some intervention has to be done. Sometimes you may wait for a longer period, up to 6 months. So, a bone bridge or a BAHA is a new treatment for children or adults with conductive hearing loss. They may have undergone a stapedotomy in the past 10 to 15 years with poor results. They have mixed hearing loss or single sided hearing deafness. So, bone bridge or a BAHA makes use of the natural ability to hear, but the way the sound is sent, we change. So it goes through bone conduction and goes to the hearing center and gives wonderful hearing results, crystal clear, natural sound. So this is the treatment of choice for patients with conductive hearing loss, failed stapedectomy, mixed hearing loss, or single-sided hearing loss. Again, the common question which patients say, I can hear well with one ear, why do I need the other ear? Nature has provided you with 2 ears. So if you don't hear from one side, in a conference you have to keep turning. You're always constantly using the phone, you can get a crick in the ear. If you're driving, you can't hear anyone honk or call out. So these, in today's day and age, the fast moving age, you cannot have 180-degree loss. So that penumbra really creates a lot of problems. So you need to advocate that you have something here called a bone bridge. This is a simple procedure which takes 1 hour and 1 day hospital stay. So it has two parts. You can see it has an external audio processor and an implant which goes into the skull, not the brain. So in the first step, this implant is a titanium this thing device which is placed behind the hairline so that incision is not seen. And after 3 weeks, the audio processor is clipped on. It's like a magnet. You can take it off when you go to swim, and it's water resistant but not waterproof. And it's has an extremely low risk of skin complications and gives wonderful results for life. So this is called a bone conduction implant. This is new, it gives wonderful results. But again, this is not covered with insurance. I would request Dr. Asrani and his team who work closely with the insurance companies, you have to tell them that they need to consider uh, providing for hearing devices because any form of implant is not covered. So, what are the other treatment options? So, a cochlear implant is an implanted hearing device which bypasses the damaged part of the ear and stimulates the hearing nerve directly. So, this is the preferred line of treatment for patients with severe to profound hearing loss who do not benefit with hearing aids. So, what are the components of the cochlear implant system? Basically, it has two parts: an internal implant placed under the skin behind the ear, and an external sound processor. Again, the Indian mindset, they don't want anything outside. But you see, no battery has been devised which will work lifelong. So, you have to have a small device which is outside. So, how does a cochlear implant system work? You have a sound processor which captures sounds and converts them into digital signals. These signals are sent from the internal implant via the coil. The implant converts the signal to electrical impulses and sends them along an electrode array to the cochlea, and the hearing nerve delivers the signal to the brain. So basically, you have an external part, you have a sound processor, you have a coil, you have an internal part, and an electrode array. So this is how an implant system works. Basically, hospital stay for this is 2 days. Operating time is 2 hours. And after 3 weeks, this implant is switched on. Surgery is only 25% of the job. 75% comes in our dedicated audiologists and auditory verbal therapists who work with the patient to understand sound, letters, words, and sentences. In a prelingual child who cannot speak, this process takes 1 to 1.5 years. So, what are our candidacy criteria? Basically, infants 12 months to 2 years is the right time. Older children 2 to 8 years who have used hearing aids may be considered. And now, the world over, you have adults who do not gain benefit from hearing aids. And now you see the age of retirement. There is no age. People keep working. They want your hearing. You need to converse. You need to participate in conversations. So you have two extremes of age who are going in for implants, the very young and the very old. Those who are post-lingual and who can speak, it's extremely quick and extremely fascinating how they're doing with cochlear implants. But it's a mindset which has to change because those days are gone where you can say, TK, I can't hear, leave it. No. Why shouldn't you have all your faculties? And it is seen that if you don't hear well, if you don't if you don't communicate, if you become a social recluse, then Alzheimer's, presenile dementia, all then set in easy. So you must be clear, you must be alert, and you must have the use of all your faculties. So, what is the journey to better hearing? Evaluation, surgery, what we call a switch on, habilitation, and maximizing the child's cochlear implant. How do you predict outcomes? The age of child at implantation. the etiology or cause of deafness, duration of deafness, additional disabilities, and most important, the motivation of the parents, because you need a family commitment. The first thing is, as a surgeon, it's a lifetime commitment, but you need a commitment from the family too, because in India it's very common that get operated and leave it to the doctor. No, we need your commitment, and if we find that the family is short of commitment, it's better not to venture into it. So the adage is either you use it or lose it. So before 5, if someone has hearing loss, it must be addressed. Every year of unmanaged hearing loss can impact comprehension and expression. So younger age at cochlear implant was associated with a significantly steeper rates and increases in comprehension and expression. What is the importance of early intervention? Ability to develop spoken language. We want the child to be in regular mainstream school at the age of 5 years. Enhance scholastic achievement, greater versatility and social robustness, more opportunities in employment, and greater social independence and quality of life. Believe me, sir, it's been extremely difficult for us working in hospitals to convince the corporates that they need to invest as part of their CSR into children with hearing disabilities, because we can work and make them responsible members of society. Because a child who cannot hear suffers in silence, society does not bother about them. So, this is something which is correctable, and the patient can become a responsible and independent member of society. So I would heed all of you to help and work with us to achieve this. So, what is the best age for an implant? 0 to 1 is optimal, 3, 4, 5 suitable, 6 to 8 outcomes variable. So, the earlier, the better. So, earlier the child is operated, his language development is like that of children with no hearing loss. So, the importance of screening for hearing loss. Who should be screened? Universal newborn screening. And now, more and more, we recommend, like they do in the armed forces, everyone should have a hearing screening done every couple of years. Our goal is 136. Infants are screened for hearing loss before hospital discharge or by the 1 month of age. Infants receive diagnostic audio evaluation by 3 months of age and enrolled in early intervention services by 6 months of age if required. So these are some of the children we've operated on. Lovely kids. You can see the smile. This child had a bilateral cochlear implant, an adult with a cochlear implant. And as you can see, the external device is becoming smaller and smaller. Here it is shown open, but if the lady pulls down her hair, the external device is not seen. These are some of the children with our government scheme. Thank you. Dr. Asrani, now the house is open for questions.
Yes, sir. I have some questions.
Yes, please. That's like.
How do you differentiate between acute suppurative otitis media and acute mastoiditis?
Sir. That's extremely important and a very good question, sir. So basically,
one of the very senior doctors, Dr. Mulchandani, has asked this question.
Yes, sir. So what is important is that you see when you have what you call as acute otitis media, basically one, acute, the history is short. Two, the patient may or may not have had similar episodes in the past. Three, the nature of the pus may be watery, serous, but it is not cheesy. Four, you may have pain to start with, but once you start antibiotics, the pain settles down. Now, when you move towards mastoiditis, one, the pain could be severe. The nature of discharge could be either foul smelling or cheesy or creamy, what they say. If you have an otoscope, if you see inside, you may see what you call a sag in the deep meatal wall. Or in simpler words, the whole canal is edematous towards the drum and you cannot visualize the upper part of the drum. Next, you may have pain, you may have spikes of fever. These are on clinical examination. Another part of the history is that the patient may have had recurrent episodes like this in the past or high grade fever. This is as far as the clinical exam is concerned. On investigation, a simple X-ray mastoid will tell you what is called as clouding of the septa, what you call breakdown of the mastoid air cells. These may point towards mastoiditis, or at times you may have a bulge behind the ear, pain in the area of the ear, what you call the cymba conchi. When you check for mastoiditis, you don't look for pain behind. You look for pain here, which is called the cymba conchi. So that is extremely painful. So these point towards mastoiditis.
Okay,
Yes.
sir. Then,
Mhm.
is there an age restriction for surgery for hearing loss since birth?
Yes, sir. So when we started out with cochlear implants, we used to operate from 1 year and above. Now, some centers are operating earlier. The youngest recommended so far is 11 months. So, when you're evaluating a child with hearing loss, first it is the trauma which the family is facing. There is denial at times in our society. Plus, again, examination, looking for comorbidities, doing a BERA, doing a CT scan, doing an MR, all this takes time. And when you're doing a screening, if you get a hearing loss at 3 months, we repeat it again after 3 months. So, all this, the child has to be enrolled in an early intervention program. And generally, we operate at 11 months of age. Now, on the other side, of age restriction is if a child has hearing loss and has not even been given a hearing aid till the age of, say, 6 or 7, then we would be hesitant to operate because the results would not be good. Because the concept of neuroplasticity, which I mentioned earlier, if you do not stimulate the center, the results are not likely to be good and the center will atrophy. So basically, as early as possible, and if hearing loss is detected, which is severe to profound, till the finances are being arranged, till the facilities are there for surgery, some kind of hearing aids and therapy is to be started.
Sir, a question. Is there any empathetic approach needed while speaking to the person with cochlear implant, like our tone and pace of speech, seating arrangement in classroom, also when they are attending parties with loud noise?
So uh, uh, you're saying, okay, what kind of approach? Okay, so now what has happened is some of the companies have now gotten new devices which are like something like a mic which is hung. So it's not necessary for the patient to be sitting on the first row. And with the help of these mics, and the patient can sit in a normal classroom and attend all conferences with ease. But again, it also depends on the kind of therapy which is being given and the kind of speech development which has been taken. So if someone has a hearing disability, someone has been operated, all these are to be addressed. But now with these new mics and devices, all these factors have been obviated, but it's an extremely good question. Thank you.
Sir, what is the cost of bone bridge and cochlear implant?
Okay, sir. So now there are two types of conductive implants, which are either bone bridge or Baha, and the cost varies from 5.2 to 5.75 lakhs. That is the cost of the implant. Stay in hospital is 1 day, and the hospital stay, everything could be around a lakh. So it is cost of implant plus 1 lakh. As far as a cochlear implant is concerned, you have an entry-level implant and the high-end implant. The smaller the external device, the cost is greater, plus the number of channels and the other facilities and apps which are there. So the entry-level implant is 4.5 lakhs, and the higher implant goes to around uh, up to 14 lakhs. So the range is from 4.3 to 14 cost of implant. I put the contact details on the chat box.
Okay, how to do ear toilet?
Okay, so that's an extremely good question.
No, and there's a related question.
Sir.
One Dr. Ashok Kothari, senior general practitioner. We senior GPs used to flush out foreign body by syringing. Also used to put few drops of dilute hydrogen peroxide for ear cleaning till few years back. Whether advisable today or not?
Okay, sir. Now, so syringing is still there to stay. The only thing is, if you're doing syringing, one, you must make sure that it is not a animate foreign body, because if you put water, sometimes vegetative or animate foreign bodies swell up and it becomes difficult to remove. If you have a small ball-like substance or a small metallic or a plastic substance which is not sharp, then syringing can be done. The only caveat is, when you're doing syringing, use clean water or distilled water. The water should be, whatever you're using, saline, should be at body temperature, and you should have adequate light, and the stream of the syringe should be directed towards the posterior part of the ear canal. So you're not directly causing trauma. It goes along the ear canal and brings out. So syringing is still there to stay, provided you take these precautions. So we have stopped using hydrogen peroxide because some people dilute it, some people don't. It causes local reactions. So, today's day and age, anything which causes the slightest reaction or local this thing, our patients are extremely sensitive. So we have stopped using hydrogen peroxide, but syringing is there to stay, be it for wax, be it for foreign bodies. Only caveat is body temperature should not be a sharp object. It should not be a vegetative or an animate object, but syringing can be done.
Offensive post-nasal discharge and pain behind the ear. Is it mastoiditis?
Offensive postnasal discharge and pain behind the ear.
Hmm.
No, sir. See, postnasal discharge, which is offensive, is basically coming from the sinus. As you know, the floor of the nose is shaped such that any secretion from the nose will drain towards the posterior part of the nose. Now, what happens is the nose secretes 1 to 1.5 liters of fluid, mucus, and secretions every day, but you don't sense this. This happens seamlessly. So when the amount is more than this, or the secretions are thick, then you're aware of this. When you have to pull and the secretions, or when you're lying down, the cough comes. So offensive purulent secretions are related to sinusitis. You may have pain behind the ear along with this if the eustachian tube gets affected. So this, basically, you have to address the sinus. It's not mastoiditis.
Are cochlear implants done for both the ears simultaneously or both are not required?
No, sir. Today, the standard of care is bilateral cochlear implants. Now, what has guided us to this? One, the quality of the implants. Two, like I had mentioned earlier, uh, you operate one, you're leaving the other one without hearing, or you may use a hearing aid. So, if finances are available, the standard of care is bilateral cochlear implants. The other thing which has enabled us to do, when we started implants, it used to take 3.5, 4, almost 5 hours per implant. But with modern technology, good anesthesia, good drilling instruments, and with experience, average time for one cochlear implant is around 1.5 to 1 hour 45 minutes. So with that, in about 3 to 3.5 hours, both implants can be done. And this is the standard of care, provided the finances are available. But
So
in
both
case
can be done
finances are,
simultaneously.
yes, can be done, but in case finances are not
Finances are
available,
available.
then it can be done sequentially also.
Can perforated eardrum heal spontaneously or always requires a plastic?
No, sir. Uh, every perforation does not require surgery. It also depends, is it acute otitis media leading to perforation, which will always mostly settle down by its own, or is it a chronic otitis media with, with secretions? So what we do is when we have a look, we look at the perforation. If the perforation does not have skin line edges, you can just see a small perforation and the margins are not thickened, it is likely to heal by itself. If the patient has had recurrent issues of ear discharge and the margins are lined with skin, it is less likely to heal. But in any case, medical management for a period of 8 weeks is essential before you plan for surgery, unless the location of the perforation is towards the posterior superior part of the ear, unless there is foul smelling discharge, severe hearing loss, extreme pain, any complications of otitis media, be it facial palsy, hearing loss, labyrinthitis, there one would intervene earlier.
So now, since we are on perforation, do you advise any ear drops for otitis media with perforation?
So generally what happens is we try and minimize the use of ear drops. One, because of um, local issues. When you used to use acetic acid, you have external ear infections. So there may be ototoxicity. So the use of eardrops has come down. And we normally take a swab and exhibit either oral or IV antibiotics. You may use topical eardrops with caution.
Okay. What is the success rate for cochlear implant and how long does the implant last? Is it lifelong or we need to change something?
No, sir, the implant per se is guaranteed for life.
Okay.
Now, the external processor, you may upgrade as newer tech, tech comes in, but the cochlear implant is guaranteed for life. As far as the success rate is concerned, sir, now you're uh, doing a high-end surgery. You're, it's extremely expensive. The expectations are high. So the success rate is extremely good, sir. Now the success rate is uh, measured by your outcomes. So if you have operated on a child and you have enabled the child to speak and attend school, then you've done your job. Likewise, if you operated on somebody who's lost hearing, who had hearing before and he could speak and he can hear well, then you've done your job. But to reach this, you have to select your patients extremely well. You have to make sure that there are no anatomical abnormalities, like, for instance, if someone has had meningitis and has lost hearing, here is one instance where you would operate as soon as possible. Because sometimes you have ossification in the cochlea and you have a condition called labyrinthitis ossificans. So even if you want to do a cochlear implant later, you may not. So the success depends again on your selection, your evaluation, the kind of therapy, the kind of outcomes which the patient is counseled upon. But the goal is that the patient has to hear and speak. Otherwise, you've not done well.
Sir, do you use nasal decongestant for ear perforation?
Yes, sir. Because you see, like the word ENT, they are
Hmm.
all interlinked. So
Yeah.
if you have a perforation, especially is it if it is towards the anterior part of the drum, it is a correlate that this could be related to some nasal issues. So in such cases, or if you find a gross deviation of the nasal septum, polyps, and sinusitis, you would use decongestants. But here again, a caveat: medicines like oxyspray, Otrivin, Nazivion are to be used maximum for a period of 3 days. Beyond that, nasal sprays, nasoclear, physiomer, saline spray are to be used. Decongestant drops are not to be used for more than 3 days. Why? Because one, They are made in distilled water. The nose is bathed in hypertonic solution, and by using distilled water for a prolonged time, the cilia of the nose get damaged. And this leads to long-term complications like empty nose syndrome, atrophic rhinitis. So we don't recommend use of decongestant drops for more than 3 days.
I must specially thank you for this because we family physicians have to tell our patients that you are harming yourself by using Otrivin and these things regularly. They just keep them in their pocket. And
So,
doctors also don't caution them at all.
so it's extremely difficult because it gives a quick response.
Yeah.
Then you have a rebound blockage. So we are forced to, keep explaining to them, show him on the endoscope that your nose is clear. And if you keep using these drops, you will have rebound blockage, which you have to keep using the drops, and it becomes a vicious cycle. And you also have to address what you call ethical advertising. You find these ads out in the paper: use
Yes, yes,
oxy
yes.
spray, use Otrivin. This has to be prescribed
Banned.
by a by a physician with the
Yeah, yeah.
caveat.
Sir, after doing a syringing cleaning, is there need for any precautionary ear drops to be put?
Yes, again, like I said, one, you've got to be sure that you're doing a syringing where there is no residual infection in that area. If you're
Hmm.
just doing it for wax, you use sterile water, then you don't need to use drops.
Okay.
And if the patient is available for a follow-up, if the patient has come from far, you're not sure about the quality or the sterility of the water, it is safer to use antibiotic drops for a few days.
There's a question, why antibiotics for fungal infection and is there any local antifungal required?
So you don't give antibiotics always for fungal infections. Antibiotics are given for a bacterial this
For
thing.
the superseded infection.
But sometimes you have a secondary fungal infection. So you may use topical drops, you may use oral antifungals, depending on the response of the patient. That's why a swab is always taken.
So there is a question, good hearing aids, Resound, Oticon, Siemens, rechargeable, which is better you'll recommend? Because see, most of us are in that age group, and what may be the approximate cost if you can guide us?
So basically, what has happened is with the advance in technology, most of the hearing aids are basically same. So what guides you is one, is it a rechargeable hearing aid? The number of channels and the cost. Now, a digital hearing aid, the costs start from approximately 35 to 40 and they move up to about 1 to 1.5. So that is the range. So what goes for you and what works for you is one, you should be comfortable. You should not have a feedback, ease of wearing, clarity of sound, different ability to adapt in different surroundings, be it your clinic, the theater, a noisy area, and your after sales service.
So what is the effect of long-term use of Bluetooth or headphone?
Okay,
Before
sir.
that, I'll ask you a very practical question.
Yes, sir.
Now, the tiniest of hearing aids
Yes,
does not allow us to use our stethoscope.
yes.
Now, I have seen on the internet that Litmans and all have stethoscopes with magnification in the earpiece. Are such things available in India?
So now I'll take it to the other this thing. So now with this new devices where you can actually hear the heartbeat and all that with the help of your iPhone, that are going to make stethoscopes obsolete soon. But what you said is not available in India. But I can check and get back to you, sir, on this.
But has any hearing device come which can be used with stethoscope also?
So basically, the thing is when you have a hearing aid in the ear and you're using your stethoscope, it's always a challenge. And I remember you asked me this a
Yeah.
couple of years back. I have to really check and get back to you, sir, for this, to give you
Okay.
an accurate answer on this.
So now this question of effect of long time use of Bluetooth or headphones.
Yes, sir. Now, this is another burning question. Now, what has happened is that you have a lobby for cell phones where you find even children playing around with cell phones and using it. So, although there have been anecdotal cases, uh, how does a cell phone, how could, let's be very this thing about it, how could the use of a cell phone damage hearing? How could, because I'm underlining the word could. So basically, what happens is when you're using a cell phone for a prolonged time, it also depends on the quality of the cell phone. Is it heating up? That's important. How long are you using it? Are there any electromagnetic waves or radiation? So basically, what has happened is the cheaper cell phones, there is a lot of local heat. And when you keep your phone against your ear for a prolonged time, that does cause some damage. That's one. It is said by some people that the electromagnetic radiation can cause hearing loss, but no study has still proven this. So it is a postulate that you should not allow a child to use a cell phone because it is, I would again underline, could be potentially hazardous. It is seen when you have tinnitus and when you have hearing loss, and you find people with a Bluetooth always, when you ask them to remove the Bluetooth to use headphones, sometimes that hearing loss and tinnitus settles down. So, yes, prolonged use of Bluetooth, prolonged use of cell phones may be damaging. It is recommended to cut down the hours you use a cell phone, shuffle it between the years. What they say is, you keep holding the cell phone to the ear till the collar comes on. Pick up the phone only after the collar comes down. That reduces your exposure. And you have a small device which you can attach to the cell phone, which is available commercially, which cuts down the radiation.
So now the question which I was holding on because it was not part of the talk today. Any treatment for tinnitus?
Okay, sir. Now, this is another thing.
It's a very tough question.
No, no, sir, but I'm telling you because we get this every day, sir. What is happening now is that what is tinnitus? Tinnitus basically is a ringing sound in the ear. Why does it occur? This may occur because of hearing loss. This may occur because of damage to the hair cells in the inner ear, either because of a viral infection, either because of acoustic trauma, sometimes because the use of aminoglycosides, sometimes because the use of high doses of analgesics, or sometimes after a diving accident, barotrauma, etc. So those are the possible causes. Now, once you have tinnitus, it depends, is it acute onset or chronic? If it is acute onset, we give a trial of medication for 3 months, which basically uh, is Tinex. We use ginseng, sometimes you use notropil. So basically, in short, you're using vitamins, we're using vasodilators to see if the tinnitus is regress. Tinex does give good results in about 15 to 20% of patients. Earlier, we used to give it IV, but now oral Tinex is used, which is safe, and we're getting decent results in 15 to 20% of patients. But if all these things have been, you've been through all this and you're still having tinnitus, which is bothersome, then we have a wonderful device which combines a hearing aid and masks the sound. So basically, before you proceed for this, you have to ask for a audiometry with a tinnitogram. So what we do is a good audiologist can find out what frequency of sound is the tinnitus and how much of sound you need to cancel it. So sometimes this is called tinnitus retraining therapy. That is sound cancels sound. So you use white noise or pink noise, basically sound at that frequency. So sometimes you present the sound at the same frequency and decibels, and that sound gives you relief. So then we invite the patient for what is called tinnitus retraining therapy. This works. Every individual is different. If this works, then we would advise them to go for a hearing aid with a tinnitus masker. And I can tell you that it is extremely gratifying. Some chronic patients who have been severely upset with the kind of tinnitus and have a certain degree of hearing loss or may not have hearing loss are doing well with this. So it is called a tinnitus masker.
Thank you very much, sir. Is myringotomy suggested for serious otitis media? And why at times it gets occluded again and again?
So when you have serious otitis media, you do medical management for a period of 2 to 3 weeks. Indications for intervention are one, persistent effusion. That's one. Two, occupation. Someone wants to get back to flying, has to fly. Someone's occupation demands it. Then you intervene. But first, medical management for at least 2 to 3 weeks. Then again, when you're going to address serious otitis media, you have to see age of the patient. Sometimes in a child with very large adenoids, grade 3, grade 4, even if you just drain the fluid, it's going to come back. So in such cases, or those cases who have recurrent serious otitis media, we just don't do a myringotomy. We do a myringotomy and put a ventilating tube, which is called a grommet.
Grommet.
So this grommet stays for a period. You have long-term grommets and short-term grommets. Short-term will come out by itself in 3 months. If serious otitis media is there in a child, it's one indication for adenoid surgery to be done in the same sitting. If it is happening recurrently in an adult, then you would do a myringotomy, a grommet, and a eustachian tube dilatation. That is new.
Sir, you have been very patient with us. One question, give us the pathophysiology or mechanism of severe ear pain developing when the flight is landing
Okay, so basically, so what is happening
or the
is,
flight takes off. Yeah.
no, normally it happens when the flight, more
Land,
happens when the flight is descending, sir, and landing.
descending, yeah.
So basically what happens, sir, that you tend either you're sleeping, one, there is rapid descent, and you may or may not have some incipient pathology, that is either a deviated nasal septum, polyps, you may have flown with a cold. So what happens that the eustachian tube is unable to equalize in a sudden, uh, equalize suddenly. So because of that rapid descent, now if you've seen, uh, if you have a short flight, the incidence of barotrauma is more than in a long flight because they descend extremely slowly and they have experienced pilots. When you have a rapid descent, that's when it happens because there's a failure of the eustachian tube to equalize. When the eustachian tube does not equalize, fluid collects either in the middle ear or in the sinus, leading to barotrauma.
Thank you, sir. Side effect of earwax, vacuum or suction treatment.
So basically, if you're doing suction for wax, firstly, you have to make sure that the wax is soft. So we recommend any wax softening drops, be it Solivax, be it glycerine, be it paraffin, be it coconut oil, be it olive oil, to be used 2 to 3 times a day for 3 to 4 days so that the wax becomes soft. Suctioning is done in a clinic where you have adequate light and you're doing it under direct vision. And if you're doing it by a trained person, direct to vision, and taking care, there are no side effects for that. So it's pretty safe.
Latest theory for Meniere's, is it vascular origin?
So basically, Meniere's is, you caught us again, a difficult thing. Now, Meniere's again is something, sir, for the treatment for which is really, really bothersome. So basically what happens is, the technical term for Meniere's is endolymphatic hydropsia. So essentially first is the history. You must have history of an aura sometimes, a fullness of warmth behind or around the ear. You may have hearing loss, which is typically low frequency hearing loss. You may have giddiness. You may have tinnitus. So it normally starts off with this. So when all these things come together, we do an audiogram, and typically you have a low frequency hearing loss in an acute setting. What is important to do? What is called a ECOG. So electrocochleogram. This is available only in a few facilities in our city, and the Mani Hospital is one, where basically you're checking the pressure of the endolymphatic fluid, and it's a very accurate, combined with an audiogram history. The ECOG gives you a very accurate interpretation that the fluid within the inner ear has built up, leading to what you call Meniere's. Again, like it's a cyclic thing. You may have remission, and basically you have to cut down the salt. You have to give medicines like Diamox. Sometimes vertigo also is associated, but essentially addressing the salt intake, taking low sodium salt, use of Diamox, sometimes a short burst of steroids when there's hearing loss does give benefit.
Lastly, there is a request to point out the area of pain of acute mastoiditis. You showed once, but there's a request of pointing out
Okay,
again.
sir. So I hope you can see me. What is important, sir? Mastoid pain is not behind the ear. That's extremely important. Secondly, if you're moving your ear and you're having pain, again, it's not mastoiditis. This is normally pain uh, uh, addressed to the external ear. Mastoid pain is here, sir. If you can see clearly, when you've got the helix there,
Yeah.
just above the external auditory ear is
Hmm.
an area called the Simba conchi. So
Simba
that when you press and you
Okay.
have pain, this tells you that the patient may have mastoiditis.
Thank you. Sir, thank you very much. There are no words to express what you taught us today. There have been a lot of good comments for you. I will share the chat with you. And my team, my participants, Dr. Badhwar will be again with us next week when we are having three doctors from Kokilaben to talk to us about robotic surgery. So he'll be enlightening us more on robotic surgery for head and neck. I must tell you, I am normally not very impressed, but he told me that he can remove a thyroid gland through the axilla. So I was really impressed, and I'm sure he shows us next time. Thank you very much, sir.
Thank you, sir. And
We are indebted to you.
not at all, sir. It's my honor. And have a good evening. And thank you for
Thank you, sir.
being
Thank you.
with us.